Romagnoli. I am an intensivist and anesthesiologist from Italy, Florence. And it's a real privilege for me to co-chair this interesting session with Professor John Callum, that everybody knows, from Pittsburgh, USA. We'll address the issue about perioperative AKI. And please, Professor Callum.
Yes, and our first speaker, maybe it's working, maybe it's not. I'll just shout. Our first speaker is my co-chair, who's going to be speaking about prevention strategies of acute kidney injury on perioperative patients.
Good morning again, Professor Callum. These are my conflict of interest. So my topic is some preventive strategies to address, to face AKI in the perioperative period. I will address the issue by touching three main aspects of the problem, some general considerations, some numbers, something about prediction scores and other systems, and finally some potential intervention to limit or to avoid acute kidney injury. Acute kidney injury in the perioperative period can be defined as quick deterioration in renal function during and just after surgery. It's associated, with a very high morbidity and mortality, especially in some surgeries like cardiac surgery, for example, in which the incidence rate is very, very high, and is very high the necessity for renal replacement therapy in these patients. And clearly costs are another problem. In this beautiful paper by Ravindra Mehta, AKI is named as the silent killer in which death rate is more than breast cancer, prostate cancer, heart failure combined together. And which are the main problems? I think two main problems. The first one is that we still do not have a specific treatment option for this syndrome. The second one is that our activities, our therapies, usually start late when we do diagnosis of AKI by using the KDIGO criteria based on a decrease in urine output and or an increase in serum creatinine. And oliguria is non-specific, is non-sensitive. Increasing serum creatinine is a very late functional marker, and especially in some conditions, like the ICU, but also the operating room, there are some important confounding factors like fluid load that may dilute the marker. So serum creatinine and oliguria are really not designed to diagnose AKI very, very early. As Melanie Mersch underlines in a very beautiful paper, the AKI is still underdiagnosed and a misunderstood problem. And this is a big problem because risk assessment and prevention are our major weapons. Pelosi states that three steps are important. Identify patients at risk, prevention, and early recognition in order to avoid the progression of the damage as soon as we can. So in the journey from starting before surgery to AKI, we can identify two steps. The first one is the injury, that is the surgical event, and the diagnosis according to KDIGO criteria that could be sometimes too late. And so it could be better to identify patients at risk before surgery or even before KDIGO criteria becomes positive, so between the injury and the increase in serum creatinine. How can we predict? It's not so easy. There are some specific contributors related to patients, but also related to surgery. Related to patients, chronic kidney disease, cardiovascular disease are among the most important. About surgery, you know very well cardiac surgery is a very high-risk surgery. Up to 30% of patients develop cardiac surgery-associated AKI because many, many reasons related to patients, but also to specific surgery, cardiopulmonary bypass, ischemia reperfusion injury, emboli, and after surgery, vasopressor exposure, nephrotoxic drugs, and so on. But not only cardiac surgery. In a major abdominal surgery, the incidence rate of AKI is still very, very high. And other surgeries are liver transplantation and liver surgery in general, and we have to talk about also nephrotoxic drugs, contrast media, and so on. As Professor Kellum in this editorial states, it's very difficult to predict development of AKI before surgery, especially with clinical data. We have some clinic scores mainly developed for cardiac surgery, less for abdominal surgery, and mainly oriented to predict severe AKI requiring dialysis. In light of this, major non-cardiac surgery really received less attention. We just have 6 scores till now, but 5 of them are related to liver surgery or liver transplantation, just 1 for general surgery, non-liver related. But the main problem is that diagnosis doesn't follow the KDIGO criteria. And so the identified independent predictors are clearly useful, but probably it's necessary an update. How can we predict a new idea, new approach, something very interesting that should be still validated in large population of patients, the renal functional reserve. That is more or less, in my mind, like to try to understand the functional reserve for cardiopulmonary function in all our patients when we ask how many daily activities they can do in order to decide how many metabolic equivalent tasks they have. Increasing serum creatinine is very late after we have lost at least 50% of the nephrons, while GFR decreases much more earlier. So in this type of test, by giving a protein load to the patient before surgery and measuring GFR, estimating GFR before the protein load and after protein load, we may try to understand how many nephrons can be recruited. If the GFR increases, the difference between the two GFR may give us an idea about the renal reserve that has been found to be lower in the elderly in some pathological states like diabetes, and in this way could tells us the vulnerability of our patients. In a recent study, it has been performed in 110 cardiac surgery patients in order to establish the capability to predict within 7 days after surgery AKI. The authors found a high incidence of low renal reserve, divided in mild, moderate, and severe, and renal reserve reduced had a very, very high predicting value for total AKI within 7 days, especially for those with an increase in GFR less than 15 milliliters. Before surgery, these new data, biomarkers, I will not discuss all of biomarkers because Professor Kellum has a specific talk during the session, but Lobdell and co-workers by testing the ST2 myocardial biomarker, identify with an odds ratio almost 2 those patients that will develop AKI after coronary artery bypass grafting in almost 1,500 patients. Between the injury and the increase in serum creatinine, we have 2 major studies. One is by Melanie Mesh in cardiac surgery, and the other by coach and co-worker in non-cardiac surgery. In these cases, they use the biomarkers to modify the treatment, to increase the monitoring, and so we shift to interventions. The paper by Gauch and co-workers, according to the Team 2 GF BP7 more than 0.3 in urines. The patients have been randomized in control intervention. Intervention groups followed the suggestions by KDIGO guidelines, discontinue nephrotoxic drugs, great attention to fluid therapy, hemodynamics in general, strict monitoring of serum creatinine and urine output, avoid hyperglycemia, and avoid, if possible, contrast media. The main intervention was related to fluid therapy just after surgery. They found a global decrease in AKI after general surgery, and especially decrease in the moderate and severe AKI, decrease in creatinine increase, decrease in length of stay in ICU and in the hospital. The study, the PRIV-AKI study by Mersch and co-workers, evaluated the same biomarker in cardiac surgery 4 hours after cardiopulmonary bypass and divided in a randomized way to intervention and control groups. Almost the same. They followed the KDIGO guideline suggestion to support better kidney function based on a PICO functional hemodynamic monitoring system. They found a global decrease in AKI in those patients, and especially in moderate and severe AKI, so 2 positive studies. Other interventions that should always be considered, especially in non-cardiac surgery, blood pressure, because blood pressure never should go below 55 millimeters of mercury, according to this important study published in 2013, in which acute kidney injury, but also myocardial injury after non-cardiac surgery increased after a few minutes of minute pressure below 55. In 2015, again, never below 55 in 10 minutes, never below 60 in 20 minutes, 5,000 patients, non-cardiac surgery, and again, last year, never below 65 for a total of 13 minutes if we want to avoid increase in AKI and myocardial injury after non-cardiac surgery. And now an important aspect that I consider very, very important. How can we minimize hypotension during surgery? That always should be minimized by using some devices and then by using fluids, vasopressors, or inotropes. We always should avoid the vasodilatory properties of anesthetic agents. And the main system is, to me, the EEG monitoring. That is not still standard of care in our operating rooms. But just to give you a very recent example, last week, in non-cardiac surgery, we had a very complex patient, a young lady with a dilated cardiomyopathy, 4 coronary stents, implantable cardiac defibrillator, low ejection fraction, moderate mitral regurgitation, severe tricuspid regurgitation, pulmonary hypertension. This is the tricuspid valve, and so it's not easy, especially in non-cardiac surgery. As Professor Kellum says, cardiac dysfunction can be reduced for 2 main reasons. The first one is a decrease in forward flow, but the other one is an increase in back pressure and venous congestion. And so in many, many of our patients, especially in cardiac surgery, but not only, right-sided heart failure and raised venous pressure increases the incidence of AKI. And we could manage this not easy patient with a very low dose hypnotic, very low dose opioid, with a good hemodynamic, without norepinephrine, without vasoactive drugs, with a mean arterial pressure always above 65, but with a careful monitoring of how we use our vasodilators that are hypnotics and opioids. Fluids, going to the conclusion, fluids are clearly important in 2 reasons. The amount, because hypovolemia, AKI, hypoperfusion, hypervolemia, fluid overload, AKI, venous congestion. Enhanced recovery after surgery programs all suggest a near zero fluid balance in non-cardiac surgery, in non-bleeding patients, and euvolemic patients. Not too much, not hypovolemia, in order to preserve organ function. And this is just a couple of papers last year, 90,000 patients. This is a fluid therapy from restrictive to liberal, 5 quintiles, first quintile, last quintile, AKI, a strong association, because probably renal congestion, increase in venous pressure, increase in pressure in the renal parenchyma. Fluids are important not only in terms of amount, but also in terms of quality, type of fluids. A very recent 2 papers published in New England Journal of Medicine. To summarize, fluids rich in chloride should always be avoided if you want to limit damage to our kidneys. And so my final considerations, to prevent AKI is not just a single intervention, it's a sort of big package of intervention that include surgeons, minimally invasive surgery is absolutely preferred, monitoring, blood pressure, processed or unprocessed EEG during surgery always. Some adjuvants, mechanical ventilation. It's a big package that starts when patient arrives at the hospital, sometimes before, with an answer recovery after surgery program, continues during surgery and after surgery. Thank you.
Very nice, very nice. That was really excellent. I agree with everything that you said. Questions, comments from the audience? Oh, come on! Surely you have something to ask. Like one of the things that I think is clearly a departure over the last few years from where maybe we have been for the